Welcome, everyone, to the Demonstrating Implementation Excellence stream of SNOMED CT Expo 2023. My name is Nick Egerhaas, and I'm the Global Vendor Engagement Lead and Customer Relations Executive, Middle East and Africa at SNOMED International. I'll be moderating today's session. All questions will be answered at the conclusion of the presentation. Online attendees, please use the Q&A button to type your questions to the presenter. On-site attendees, please use the mic provided in the room. Now pleased to introduce Filip Veldeman from Terra Nova Healthcare and Mark Helbert from ZAS, who will be presenting implementation of a hospital-wide SNOMED CT problem list in ZAS in Belgium. Filip and Mark, please proceed.
Thank you and welcome everybody. So indeed, we will tell you about our implementation of a hospital-wide SNOMED CT problem list in ZAS. I'm Filip Veldeman and Mark Helbert here with me. We will do this presentation together. To give you a bit of an idea what the situation in Belgium is like, we have a strong interoperability infrastructure in Belgium, meaning that there are services in place which are basic services for identification, for timestamping, for all that kind of things, for resources of who is who in healthcare and who can do what, and how an index as well, that if somebody is admitted in a hospital, that we can see, okay, where else has the patient been and where else is information available, and that we can actually get this information and see it. So that's a healthcare infrastructure that was based on a Belgian XML standard, KMER, kind messages for electronic health records, which is now moving to FHIR resources. On the SNOMED side, SNOMED, the first Belgian extension, was there since March 2008, and that was important because in Belgium we have the northern part of Belgium that speaks Flemish or Dutch, and the southern part of Belgium that speaks French, so we needed the translations in both languages. So that was a huge effort in the beginning to start with SNOMED CT. And also, since a while we have now a published problem list ref set that we use. I will tell about that later. We also have Belgium meaningful use criteria, where it's stated that a problem list should be available. That's the second point in the Belgium meaningful use. The first one is that you have a unique patient identifier. It's pretty obvious, but the second one is a problem list, where it says a persistent and managed Belgian SNOMED CT coded list of identified diagnoses or problems or previous procedures performed that may influence clinical decision-making and care provision. So also everything is in place to do something with the problem list with SNOMED CT. There is governance, there is infrastructure, and that gives a bit of context of the Belgian situation. Mark will now say something more about ZAS and how we started with this project.
Thank you. So indeed, understanding why we went on to this implementation of a hospital-wide problem list, I need to give a little bit more context. That is the Belgian. Okay. The Belgian Federal Public Health Government Agency proclaimed SNOMED CT as the clinical reference terminology and clearly made understood to hospitals that they should prepare for this. On the other hand, there is rather limited literature on hospital-wide implementations of a problem list. Actual trigger for taking this decision in our hospital group was the commissioning of a common best-of-suite EHR system, and it was within this context that the decision was made on creating this hospital-wide SNOMED CT coded problem list. And it was thought that this problem list would make us or would enable us to realize strategic goals such as register once, use many, process automation and increasing efficiency, increased quality of care through unified language or unity of language, and also to prepare for extramural data exchange in a more structured way. Just let me shortly present to you ZAS Hospital Group. We are a hospital in Belgium. Belgium is one of the 27 EU countries. We lie in the north of Belgium, the Flemish-speaking part, more specifically in the port city of Antwerp. Antwerp is connected to the North Sea through a stream, the Schelde River, and the ZAS stands for Hospital at the River. And I'm proud to show you the picture of our latest hospital, which we just opened near the water 1 month ago. We consist of 12 hospitals, 11 residential care centers. We have more than 10,000 employees, including more than 1,000 physicians, 95% of which are self-employed, and we provide daily care to more than 6,000 patients.
Okay, so for the problem list, there were two things that we wanted to do. First of all, to get to a structured problem list in SNOMED CT, we wanted to do an initial migration with natural language processing to get actually a good first step to begin with, to get the first qualitative start with a problem list in SNOMED CT out of the free text letters. That was one thing. And then we also implemented a change management process and ways to also these new diagnoses and things with lists. I talk about that later. But for the first step, getting the information out of the problems and the procedures out of the letters and into the problem list, we initiated a natural language process project where you see here the different steps. Where the green things are the production process, and the gray ones underneath is more the quality control underneath and the audit trailing and being able to know at all points in time what we've done. So that was all about patient selection and then document selection, which documents have the information that we need and which documents don't, so that we don't have too much noise of things we don't want or things that pollute the actual information that we need. Then the natural language processing processed this free text and put it into codes, into SNOMED CT. We then also had a step that we called pre-validation, where we used other structured information of ICD-10, for instance, to pre-validate the outcomes of the natural language processing, to have some relief, to know, okay, for this code, we have other evidence, so it's kind of almost pre-validated. We know that it's a good code, that's a feasible thing to present to the doctors. Then there was a whole quality control, post-processing step. Why? Because there was two big sites with two NLP instances. So that we had also, at the same time, a patient merging process going on. So we had to make sure that if we had the same diagnosis on both sides, that we showed it only once and not 2 times. Also that if things were wrong or false positive or so, and we couldn't fix it in time in the natural language processing, that we filtered it out. Also that we filtered out things that were correct, but that we didn't think it's good problem list material, so it doesn't belong there, so let's get rid of it, otherwise the problem list is too long. So all those things, then we migrated everything to the new medical record. And a very important step is the last block there, is that we also provided a mechanism for clinical validation. So in the end, the doctors had to say, thank you, no, not this, thank you, no, not that. So we didn't pretend to say, it will be 100% correct, but it will be a qualitative kickstart. But it's your job as a doctor to accept, and only then it becomes a part of the medical record. So that's this important step of validation in the record. And then you see when they validated it, they can start to use it also in their reporting. Okay. Mark?
So then the second step was indeed the implementation of this new, The second step was then indeed the implementation of this new problem list system within the new EHR. And we realized very well that it was a very big change for our physicians, as they were not doing any structured registration in the old EHR systems. So this organizational readiness, we were aware of the fact that we had to create that. We actually did that in the beginning of our EH commissioning process by defining certain EH principles within our organization. And for examples, these were principles, there were 8 principles, and 2 of them were register once, use many is a basic prerequisite. Another one was we will properly use the EH functionalities in the way they are intended for using. And maintenance of a hospital-wide structured problem list was actually presented as a key example of these 2 principles. We had these principles endorsed by hospital management, by the EHR steering committee, and also by the medical councils of the 2 hospitals that were actually participating. The second thing is indeed, which Philip already mentioned, regarding the whole migration process. This migration process, the final step was a clinical validation. And so we were very transparent from the beginning in what the quality of the NLP results would be, as well as the fact that they would have to be validated and that some diagnoses would not be present, they would have to be added, some would not be correct, and they would have to be removed. A second foundation on which our implementation was founded is governance, and we realized well that we needed something like a terminology or a problem list steering group within the hospital, and we set up such a steering group, and we actively put in clinicians and their representatives, and we actually put them in the lead of this steering group. Of course, there were also representatives of other departments, other stakeholders present, such as medical registration service, clinical data analysis people, terminologists, and IT people or technical application managers. This steering group actually came up with what we called problem list design guidelines for the problem list within our EHR. And these were things such as the problem list is to be designed for hospital-wide use, so all specialties. It will contain both diagnoses and procedures. We will not confront in the new EHR physicians with an empty problem list, so the information will be migrated. It will be the information to be put in is primarily intended for clinical purpose, so for clinicians, not for billing purposes or administrative purposes. We said that we want to propose or have available a customizable view, that is that different disciplines should have the possibility to select relevant lines according to their specialty. There should also, in using SNOMED CT as a terminology, be a balance between standardization and customization. For example, regarding missing synonyms, we indeed declared from the beginning that if they would be clinically relevant, we would add them in our local context. We said that we would put a lot of energy into optimizing search performances and have local or individual favorite lists available for clinicians. And we also agreed on the fact that we would only show the preferred terms regardless of which synonym was used to find these preferred terms, as the idea was the unity of language. We also said that we would use experiences, deliverables, and lessons learned from other hospitals, such as translations or vocabularies already being made up. But on the contrary, that afterwards we would also document and share our own experiences for the general benefit. Apart from these design guidelines, the terminology steering group also developed what we call problem list proper use guidelines. I'll give you a few examples. The first one being that the problem list is maintained by clinicians as much as possible in real time, although we had to nuance this, especially in the outpatient setting, because of the complexity of long problem lists and the limited time for clinicians to maintain a problem list in an outpatient setting. Each line should contain one structured concept, not less than one structured concept, not more than one structured concept. And an important one is that expansion of concepts of lines with free text is possible at all times, but the idea is that the expansion must be relevant or related to the concept. You should not add too many other concepts to align. We also had guidelines on the desired granularity of SNOMED CT concept registering, where the idea is that the desired granularity is the one at which a concept is relevant hospital-wide for different disciplines. And finally, we also had guidance on relevant content and registration issues, such as, for example, what do you do with a diagnosis which has multiple episodes, for example, pyelonephritis, which has several instances.
We also paid attention to, okay, once the migration is done and you don't start with an empty problem list, what do you do to register the new diagnosis that you have? And there we have a way of working with, on the one hand, a problem list, which is containing the more general concepts that are shared across the board with all specialties. So everybody has that as the same basis for registration, both for the problem list as for diagnosis, common diagnosis. But every specialty can also add on top of that a specific set of more detailed diagnoses for their own use, and those can be different for orthopedic surgeons as for cardiologists and so on. And so every specialty has a combination of those problem list items plus their own specialty diagnosis. That's one thing on the content that we offer. Apart from that, and that has more to do with the features in the medical record, they can also choose, if they don't find what they need, to pick another pick list, so to go to a broader list or to go to a list of another specialty to have another set of options to choose from. Or if they like, they can dive down into the SNOMED hierarchy. They can open with a little plus the detail and go one level down if they like to pick something there. That's also a possibility. Plus the things that they use a lot, they have features to give something a star as commonly used or favorite type of concept that they can easily find back to make it as easy as possible. So that's how it was implemented. Mark?
What we also thought was very important for actual use of the problem list is the integration of the problem list imputation process within the clinical registration workflow. Of course, this is dependent a lot on the EHR which you are using, but nevertheless, I think a general or a few general concepts can be presented. First of all, we believe that the problem list should at all times actually be present or must be within the overview of the clinician doing his clinical registration process. So we can constantly refer to what problems are already known, and when I actually define a new diagnosis or a problem I'm confronted with, this is already there, and so I can register my new diagnosis. Of course, the way in which you should register a problem should also be very much near this clinical registration workflow. And in our EHR, for example, you can see this view where totally on the left, the pinkish regions, you see the problem list, where the right area is the place where the doctor will put his clinical note. And the doctor has the possibility of adding the problem by either putting it directly in the problem list or by just pushing on a button within his clinical registration note, which will give him a sort of wizard for adding a new problem.
Yep. When it comes to clinical training, we asked the doctors before we started with the actual use of the new medical records to cooperate in telling us what they wanted as a specific diagnosis for their use, so they could influence the type of choices they got. Some of them have done that very elaborately, and others not so much or not at all. And those started off then with just the standard things that were in the problem list. We learned them how to use with it, how it worked with this combination of problem lists and specialty lists, how they could switch from lists and things like that. Why we did this with SNOMED CT and why what the options were or what the benefits were of working like that. Plus, we also encouraged them to report if they saw things that were not good. Sometimes something can happen with an NLP result, for instance, an abbreviation that is misinterpreted and leads to a false positive result. we asked them, if you see something, let us know so that we can interact and so that we can see, okay, what happened? Why did this happen? Where else did this happen? So that we could actually proactively clean up some things and make it as easy and as good as possible. Okay. Also, instead of being annoyed each time over and over again if they don't find something, or if they find they don't like the preferred term, or they don't find something with some synonym or whatever, if they report it, we can see, okay, it is in there, but it misses some translation, or there is something funny with the translation or something inconsistent, and that's why you find this term and not the other term, so that we can actually use their input to make it better for their own benefit, but also to report it back to the NRC so that it can improve the actual Belgian extension as well. Also repeat training sessions were also something that were needed, because we introduced this together with a whole new medical record, and there were so many things to learn and to do with the new record, prescriptions, new way of documenting, everything was new. So only this was already a lot, let alone in combination with all the rest. So it was necessary to repeat some of those things. Also, we put a quality and control process in place to see, okay, how is it going? Every month we analyze where do we get with our efforts, to also come to this continuous improvement process. And we can show you here some numbers. We see that in 14% of the patients, there is no structured registration. We thought, wow, how does that come? But often it is somebody who comes into the hospital for a normal delivery, for instance, and the delivery that's not something that goes into the problem list, or there are healthy patients with some small intervention that does not end up in the problem list. So there is some improvements to do there, but that was not so bad. And then when we look at the validated lines, the lines that they use for their actual reporting, we see now, and the latest figures were up to 85% of all the lines, the validated lines that have SNOMED CT. So we were very happy with that. We also see that if patients come back and we compare, okay, what was it in May, for instance, and what is it now that the patient is coming back in September, when they added 2 more lines to the problem list, even 95% of that is done in structure and only 5% in free text. So there will also be people who don't get it, who don't want it, who don't understand it, who don't find it, or things on our side with our lists that are not perfect yet or that can be improved. But I think we're pretty happy with this result, and we try to, with this monthly follow-up, we try to make it as good as we can. In the next slide. I've talked about this Deming cycle. So not only for our internal process, improvement process that goes, but also we have projects where we bring in other hospitals to also look at the lists that we made, to help us validate them, and finally to also hand them over to the National Release Center so that they can become part of the Belgian extension. So that was also the intention from the beginning, that the work that we put in it, that we try to publish as much for our colleagues in the other hospitals.
So some lessons learned. Some lessons learned. First of all, you all know structured data entry by clinicians is not self-evident, and we should actually wonder, and we should get a better image on worldwide how much this is actually happening. And the fact that we find few publications on hospital-wide implementations and few best practice guidelines, the question can be asked, is this the cause or is this the consequence? We think that the solution is indeed thinking about this as part of a real change management program, that you should, within this change management program, clearly provide clinicians insight into the possible future advantage of structured registration, and probably this should be integrated into basic physician education programs, which is not the case now. You should have simple and user-friendly accessibility for desired terms. We went into that already. We should have automated reuse, which we built in our EHR system. So these problem lists are automatically put into the discharge letters. Doctors don't have to do anything for that. And we should also promote and realize the reuse of these structured lists across hospitals, because we now have the possibility in Belgium to see the problem lists or discharge letters from patients in other hospitals, but these are just PDFs. You can't reuse any information structured. So the register once, use many is actually only realized within your own hospital or hospital group, which is a pity. On the use of SNOMED CT as your coding system, our lessons learned is that preferred concepts are quite often not always matching with clinician language, and this will really hamper adoption. A classic example is, for example, hypertensive disorder, which is translated literally into our language and which is not the term clinicians want to see in the discharge letter. It's arterial hypertension. Search may be complicated by missing synonyms or by spelling issues within synonyms, and this can really be very frustrating for doctors. So you should address these and solve them within your EHR, and the next step is solve them nationally and internationally. And there is also a problem, especially in the beginning, we did not have all our concepts translated into our Flemish language yet. So we borrowed information from our Dutch colleagues, but also that was not totally solving the problem. More lessons learned is the fact that if you want to use a hospital-wide problem list, one size indeed does not fit all. And this goes in two directions. First, clinicians of a certain specialty, they do not want to see all the lines which are present in a problem list. So you should solve this by giving them customizable views and having them giving them the possibilities to select only the relevant lines or highlight the relevant lines, which is of course dependent on your EHR functionality. Another thing is that indeed not all clinicians want to see the same level of granularity of a problem list line, and you should also offer guidelines on that. You can correct that, or you can steer that by the content of the discipline-specific lists. So that's a possibility. And of course, there will also be clinicians that do want to do it very granularly, so you must give them a sort of an escape if they insist on it. Or you must give them the possibility to nuance through free text. Okay, I'll do this as a last slide maybe. One big problem is also that a problem list is often a flat problem list, and that it does not give the clinician the possibility to provide insight into relevant dependencies and or relationships between concepts. The solution can be to give nuance possibility through free text, but that will only be part of the solution. The other possibility would be to offer hierarchy within the problem list, but of course that is also dependent on EHR functionality. We will conclude by this slide, and I will just give you the high-level conclusion. So you should provide easy-to-use data entry. You should especially use a listen and learn strategy. That is, you should really listen to your clinicians and provide a quick response if they have problems. You should have them participate in the terminology governance. You should deploy clinician engagement in optimizing their vocabularies, and you should invest in continuous clinician education. Only then, we think, if you address all these human factors as next to technological factors, you can come to a certain degree of implementation success. And you should share your implementation experiences so other hospitals can learn from the errors you have made. Yeah, we'll skip this one.
Well, very briefly, what we are doing for the future is trying to represent a problem list in two layers, main lines and detailed lines. The main lines are on every discharge letter, and the detailed lines, there you can say, yeah, I want them or I don't want to see them. I want to open it up, or I don't want to open it up, or I want it on my letter or not. But that brings a bit of, yeah, it's helpful for long problem lists that you can say, okay, these are the essential things, and the other things are more detailed. It's a way of trying to make it as user-friendly as possible. And another thing we're working on in the Belgian context is that hospitals will be able, that's a project for the coming 2 years, to publish their own problem list in a FHIR way in a FHIR resource. They will be able to see, is there another problem list, maybe with other information somewhere else, that you can see it in the viewer, see, okay, what's new, what's different, and that you can there validate, that's something that I don't have yet, validate, and that you pull it back into your own medical records. So that's how we will try to realize register once and reuse multiple times, but across the board. So that's something that we will try to do in the 2 years to come, where we would like to report on in 2025 on the SNOMED CT Expo then. So come and see, not next week, but in 2 years' time. Thank you very much.
And with that, we'll conclude this session. Thanks, Philip and Mark.